There was quite a lot of good data on gynecological malignancy, in particular ovarian cancer at ASCO this year. And I'm pleased to introduce Marcia Hall, Charlie Gawley, Rosie Lord, and Shabani Neekum, who are going to discuss some of the key presentations.
Welcome to the webcast for gynae cancers, and I'm Marcia Hall from Mount Vernon Cancer Centre. And the first thing I just want to point out is when we did this last year, there were four basic areas that we looked at: anti-angiogenics, PARP inhibitors, dose-dense chemotherapy, and EGFR inhibitors. And you'll be very pleased to hear that three of those are very similar this year, but they do show some development and some differences. So listen carefully, and I hope you enjoy this webcast of a very quickly put together recent debate and discussion on some new things in gynae cancers. So the first thing that I want to just quickly dispense with to some extent is the final results of a trial OV16, which is an additional doublet trial to the ICON-5 trial that those of you who are as old as me will remember, which is basically trying to give more chemotherapy in sequential doublets and see whether that adds to an increased PFS and OS. And the answer is it didn't in ICON-5, which was a much bigger trial than this, and I'm sorry to say it doesn't in this trial either. So suffice to say that this has supported our previous knowledge of ICON-5 data. Now, a much more interesting thing to do with chemotherapy and ovary cancer is in fact the scheduling. And you might remember from last year, we had some survival data from the Japanese study where they actually looked at 3-weekly carboplatin Taxol in a group of epithelial ovarian cancer patients and contrasted it with 3-weekly carboplatin and weekly paclitaxel in the same group of patients. And they followed these patients up for 6 years and have shown quite a significant survival benefit. Now, we had more this year on scheduling in chemotherapy. And you'll be pleased to hear it's not the same sort of trial as the Japanese. For that, I think we're going to wait for ICON-8 to see whether that will confirm or refute this Japanese data. But it also has something to do with ICON-8 in that it's one of the other arms. So this is a trial called MITO-7, and I'm going to hand over to my colleague Shabani Neekum from Oxford, who's going to tell us a lot more about this data.
So thank you very much, Marcia. So I'd like to just present the data that we heard today on the MITO-7 study. This is a study, a phase 3 randomized study looking at patients with stage 1C or up to 4 epithelial ovarian cancer. Patients were randomized after surgery to receive either 3-weekly carboplatin and Taxol or weekly carboplatin and weekly Taxol. They randomized 882 patients, and they received either carboplatin at a dose of AUC 6 together with Taxol 175 milligrams per meter squared, which is the standard treatment that we use worldwide, or received carboplatin AUC 2 and Taxol at a dose of 60 milligrams per meter squared, day 1, 8, and 15, and that was given 3 weekly for 18 weeks. And you may notice that that's a slightly smaller dose than was received on the Japanese study, where they received 80 milligrams per meter squared of the Taxol. The primary endpoint was initially quality of life, but that was changed after the Japanese study to include progression-free survival, and that was in 2010 that change, the amendment was made. Secondary endpoints include overall survival, overall response rates, and quality of life data and toxicity data. So the results, patients' characteristics were well matched in both arms. 70% of patients actually had stage 3 or 4 disease, which is pretty much what we would expect to see in clinical practice, and 50% of these patients achieved no residual disease after their primary surgery. There was an equal incidence of febrile neutropenia, but more neutropenia and thrombocytopenia in the 3-weekly arm compared to the weekly arm. There was significant improvement in quality of life in patients receiving weekly treatment as opposed to 3-weekly treatment. Interestingly, the progression-free survival actually showed no significant difference. So there was 16.5 months in patients receiving the treatment 3 weekly versus 18.8 months in patients who received the weekly treatment. And this did not reach the pre-specified hazard ratio of 0.75, so it was not significant in this group of patients. Overall survival data is not yet available, as those endpoints as that endpoint has not been reached yet. So the key messages I'd just like to present is that the Japanese study certainly showed an improvement in progression-free and overall survival in patients receiving dose-dense chemotherapy. The MITO-7 study actually showed no difference in progression-free survival, but did show an improvement in quality of life in patients receiving weekly dose-dense treatment. So this raises a few important questions. Do pharmacogenomics play a role in response to weekly treatments? Was the dose of Taxol adequate in the study, in the MITO-7 study, as patients received 60 milligrams per meter squared as opposed to 80 milligrams per meter squared? Certainly, the tolerability at 60 milligrams per meter squared was significantly improved compared to the Japanese study. And as Marcia has mentioned already, we do await results of other dose-dense treatment studies, such as the ICON-8 study, to clarify some of these issues.
Thank you very much, Shabani. The next issue is anti-angiogenics in ovary cancer. And again, you might remember from last year, there was some nice overall survival data in a UK trial, ICON-7. This was only an interim, and you'll be pleased to hear that I think the updated overall survival data is going to be presented at ESMO later this year. But to remind you, the addition of Bevacizumab in frontline epithelial ovarian cancer, together with standard chemotherapy and given as maintenance for up to 12 months afterwards, does in the high-risk group lead to a median overall survival benefit of around 8 months. Now, this year on the anti-angiogenic scene, we had a different agent. We had a drug called Pazopanib, which is an oral drug. Now, Pazopanib has been licensed for use and is useful as an anti-angiogenic in a number of other oncology conditions. So it's licensed in sarcoma and in renal cancer. And this was a predominantly German-led study, but from centres all across Europe, where they took ladies with stage 2 to 4 standard epithelial ovarian or fallopian tube primary peritoneal cancer. They did the usual surgical treatments and intravenous chemotherapy. In fact, they were allowed IP chemotherapy, they were allowed interval debulking, so standard treatment. And once those ladies had completed all their treatment, they were deemed eligible to enter the Pazopanib study if they had less than 2 centimetre residual disease at their operation and no obvious evidence of progressive disease by RECIST criteria on the chemotherapy. They were then randomised to either receive Pazopanib 800 milligrams daily or placebo. Now, you may ask, why did they not use Pazopanib with the chemotherapy as the Bevacizumab has been used, with the theory being that if you can give an anti-angiogenic with chemotherapy, you might deliver more and therefore perhaps better treatment to the residual tumour. And the answer is that the early studies of Pazopanib have shown that it's too toxic to be given alongside cytotoxics. So this is a purely maintenance study. And they were given the Pazopanib and placebo for 24 months or up to 24 months, followed by a period of observation. And the follow-up, one of the primary endpoints was PFS, but they were then followed up for overall survival. So underneath in this slide, you'll see that the primary endpoint, PFS, did show a benefit of 17.9 months in the treatment arm, the Pazopanib arm, versus 12.3 months in the placebo arm. So again, it seems to be the anti-angiogenics all have about a 6-month progression-free survival benefit, hazard ratio of 0.766. The overall survival data is not yet mature. In fact, it's quite a long way off being mature. I don't think we can expect that for a couple of years. They also looked at PFS by a couple of other criteria, by the GCIG CA125 criteria, and also a 3-year PFS. And both of those had similar hazard ratios and similar outcomes to favour the Pazopanib arm. Now, the difference perhaps in the Bevacizumab anti-angiogenics is that Pazopanib seems to cause quite a lot more hypertension. So 52% of the treated group had grade 2 hypertension, and it's to be noted that 17% developed grade 2 hypertension in the placebo arm, so I'm not sure whether that says something about women with ovary cancer or whether it really is truly well, obviously there's an extra anti-angiogenic effect. But perhaps more importantly, grade 3-4 hypertension was seen in the treatment arm, the Pazopanib arm, at 31%. And the other safety issue that we have to consider is that 58% of that population required a dose reduction. And this was especially prevalent in the 25% Asian population within the study here. There was also quality of life endpoints. But I think useful today to have this update that anti-angiogenic therapy is useful in ovary cancer. It's not going to go away. There are some key messages This is the first targeted therapy to show a benefit in maintenance alone, but we still need answers to a couple more questions. I think it's important that we try and find some biomarkers for who benefits most from anti-angiogenic agents, and it's still very unclear whether these should be utilised in first line or relapse, or maybe both, and that's a trial which has only just started recruiting, but is a very important trial to decide whether repeating your anti-angiogenic therapy actually helps keep remission for longer. So moving on, the next issue that I'd like to discuss is thinking about neoadjuvant chemotherapy, and we have our own homegrown trial which called the CHORUS trial, which has been ran for quite a number of years, spearheaded by Sean Kehoe, and he came to present this today. Now, as a background, there have been 4 large randomized trials. Only one actually has reported, and the principle behind all of this is whether neoadjuvant chemotherapy can downstage or perhaps convert a poor prognosis ovary cancer patient into a much better prognosis patient. And the basis for this is the evidence that the survival is better if you can remove all residual disease at surgery versus leaving any residual disease. And there are some very good Kaplan-Meier curves that actually show you that if you have less than 1 centimetre residual disease, it's better than having less than 2 centimetres residual disease, better than greater than 2 centimetre residual disease, and obviously all better than stage 4 disease, where you clearly can't remove it all. So of those 4 large randomized trials, the only one that has actually been published to date until today is Ignace Vergote's trial, published a couple of years ago. And today's trial actually dovetails very nicely into that. So Ignace Vergote's results basically showed that there was no difference if you did your surgical treatment for ovary cancer upfront as UDS on this particular Kaplan-Meier curve, or whether you did neoadjuvant chemotherapy and did the surgery after 3 cycles of chemotherapy, retaining the other 3 cycles for post-operative treatment. You can see from this slide the only arm which perhaps does any worse is the stage 4 patients who have primary surgery. And just to remind people here that the chemotherapy is exactly the same and the number of cycles is exactly the same, it's just where you position the surgery. Now, we're very lucky to have Rosie Lord from Clatterbridge to discuss some of the finer details of Sean's trial, and I think what I'm going to do is flick back to the slide that outlines that, and Rosie's going to come and talk you through it.
Well, thank you very much, Marcia, and as Marcia said, this was a presentation today on the MRC CHORUS trial, a trial of chemotherapy or upfront surgery for newly diagnosed advanced ovarian cancer. And patients included in this were those with stage 3 and stage 4 bulky disease, and they were randomized to receive either neoadjuvant chemotherapy with 3 cycles of platinum-based chemotherapy and then surgery, with completing 3 further cycles of chemotherapy, or primary surgery followed by 6 cycles of adjuvant platinum-based chemotherapy. There are approximately 270 patients in each arm. These were recruited from a large number of sites throughout the UK, and approximately 75% of patients received combination carboplatin and Taxol chemotherapy. The trial has been designed as a non-inferiority study with a primary endpoint of overall survival, the secondary endpoints of progression-free survival, toxicity, and quality of life data. So again, as Marcia said, this trial is one of 4 large randomized trials trying to address the question of neoadjuvant chemotherapy and whether it can actually convert a poor prognosis patient into a better prognosis patient. The only one published to date is Ignace Vergote's EORTC study, which was published in the New England Journal in 2010 and showed that a patient did as well receiving neoadjuvant chemotherapy and actually probably had better surgical morbidity. There are 2 further trials which have not yet reported. And you've seen this slide already, but just to point out that the patient group that did the worst were those who had bulky stage 4 disease and underwent primary surgery. And those who received delayed primary surgery in this group did significantly better. This is the results slide from the CHORUS study, and I think the main take-home message from this is that really most grade 3 surgical adverse events were actually better in the neoadjuvant arm, and in particular the discharge within 14 days was much better within the neoadjuvant group. We also see that the debulking rates were improved from 15 to 35% to zero residual disease, and the overall survival and the progression-free survivals were both improved in the neoadjuvant chemotherapy group. So I think it's important to consider which patients really we should be looking at for neoadjuvant chemotherapy, and when combined with the ORTC data, we actually find that this was very much an older population for a clinical trial. The median age of patients in the study was in the mid-60s, and 20% of patients were of PS2 or 3, which is quite unusual for a clinical trial. The discussion around this study really revolved around the potential concerns about surgical quality in these studies, and that in actual fact most debulking operations were of somewhere in the region of 2 hours, which in many parts of the world is not considered an optimal time for surgery. Of note also, there was a significant mortality in the primary surgery arm within 28 days of surgery of almost 6% in the CHORUS study versus a slightly lower rate in the EORTC study, and this did cause some concern. But what we do see is that actually debulking to less than 1 centimetre disease in both these groups probably was in the region of about 41%, which is lower than in similar European studies, but not within this poor prognostic patient group.
Right, the last topic that we've chosen to discuss on this update for you is the next instalment of PARP inhibitors. So you may remember last year we presented the outline of a trial, in fact from Canada, which is very similar to the trial that we're going to discuss here. This Olaparib study 19 was in fact discussed 2 years ago at ASCO, and those of you who can remember that far back might remember this really quite staggering separation of a PFS curve, which got everybody incredibly excited about PARP inhibitors in ovary cancer. Now, last year's data was a very early similar presentation of a smaller group of patients from Canada with a similar sort of hazard ratio for the PFS. And we've got Charlie Gawley here, Professor of Cancer Medicine up in Edinburgh, who has a great interest in PARP inhibitors, and he's going to describe the next step of what's happened to Olaparib since we saw this curve a couple of years ago. Charlie.
Thanks, Marcia. So, as Marcia said, this is a study that was first presented a couple of years ago, and it was published in the New England Journal of Medicine in April last year. And this is the initial survival curve, or the progression-free survival curve. Progression-free survival was the primary endpoint of this study. And these were patients with relapsed ovarian cancer who'd received platinum-based chemotherapy and responded to that, and then they were subsequently randomized to either Olaparib or placebo. And as you can see, the hazard ratio is 0.35, and it's highly statistically significant. So what is new here is that when this study was initially done, the BRCA1 and BRCA2 mutation status was known for some patients, but wasn't known for other patients. And so an effort has been made to retrospectively analyze blood for germline BRCA1 and BRCA2 mutation status and tumour for the status in the tumour. And the results of this retrospective analysis are shown here. So as you can see, there were germline BRCA1 and BRCA2 mutations were detected in 71 patients. And there were also 3 patients in whom a germline BRCA1, BRCA2 mutation had been detected, but in whom a tumour BRCA1 or BRCA2 mutation was not detected. It now turns out that that was probably a false negative result of the tumour testing. And then in the first column there, you'll see that there were in addition 20 patients who did not have a germline BRCA1 or BRCA2 mutation who turned out to have a tumour BRCA1 or BRCA2 mutation. So one would assume that those are somatically derived mutations. So at the end of the day, that's left a frequency of BRCA mutation, whether that be from the germline or somatically derived, of 51%. 44.5% of patients were BRCA1 and BRCA2 wild type, and 4.2% the BRCA1 and BRCA2 status was still unknown. So what was presented today was a reanalysis of this data, taking into account the BRCA1 and BRCA2 mutation status. So this is quite a complex slide, but these survival curves here show the progression-free survival when you look at patients according to their BRCA mutation status. So the patients that do most well are the patients who carry a germline BRCA1 or BRCA2 mutation, and they have a median progression-free survival of 11.2 months. The mutation carriers who got placebo as opposed to Olaparib, they have a progression-free survival of 4.3 months, and the hazard ratio on that difference is a quite staggering 0.18, with, again, a highly significant p-value. So what that suggests is that the rate of relapse in these patients who receive Olaparib, if they've got a BRCA1 or BRCA2 mutation, is far, far less. Interestingly, when we look at the BRCA wild-type patients and compare the outcome in those who received Olaparib to those who received placebo, there was still a significant difference with a hazard ratio of 0.53. So there must be some benefit in non-BRCA1, BRCA2 mutation carriers. So whether that's due to epigenetic inactivation of the genes, or whether it's due to inactivation of other genes in the pathway, such as the Fanconi anemia genes or the RAD51 genes, remains to be seen, but that is an interesting finding in itself. So the next question was whether BRCA mutation status affected overall survival analysis. And in the first analysis, which was an immature analysis, there was no benefit seen in overall survival. The survival curve here shows only the patients who had BRCA1 or BRCA2 mutations. And as you can see, there is a trend towards an improvement in overall survival in the BRCA1 and BRCA2 mutation carriers who received Olaparib. The hazard ratio is 0.74, but it doesn't reach statistical significance. Now, what might be quite important in this respect is the fact that 14 out of the 62 placebo patients subsequently got a PARP inhibitor later in their patient journey. So that's a crossover rate of 22.6%. So it is possible that that has contributed to this not being quite statistically significant. I think it's enough to say that there is a potential for these agents to be beneficial in terms of overall survival. Another survival curve on this figure here is a newish concept, and that is PFS2, which is a way of looking at the time till progression after the subsequent treatment after Olaparib. And once again, in the BRCA1 and BRCA2 mutation carriers, there is a very, very significant improvement in time to PFS2 in those who received Olaparib. And once again, there is also a statistically significant benefit in the patients who don't have a BRCA1 or BRCA2 mutation. Just to sum up, patients with BRCA1 and BRCA2 mutations seem to get a very significant benefit from maintenance Olaparib therapy after receiving platinum-based chemotherapy. There is also a benefit for the non-BRCA1 and BRCA2 mutation carriers, but that is less. For both of those patient groups, there's a benefit in PFS2. And then when we look at overall survival, most of the benefit appears to be in the BRCA1 and BRCA2 mutation carriers. Now, it may be very relevant that at this point in time, or as of a week ago, there were 26 patients still receiving drug on this study. 23 of these patients are on Olaparib, and the other 3 are on placebo. So there may be a tail to these survival curves, and there may be a subset of patients who do extremely well when they receive Olaparib.
Okay, so thank you very much for all these presentations. I think it's been a very interesting afternoon, actually, and it's very nice to see a continuation of some of these themes from last year, which I hope that as trainees you can pick up on and see an unwrapping and involving story. I'm going to go backwards a little bit, and I'm going to start with the PARP inhibitors and ask Charlie and actually Shabani and Rosie. There's a couple of things that strike me about the story of PARP inhibitors, and one of them might be a bit of gossip, but certainly there has been some inclination to suggest that patients who have BRCA mutations on the whole respond very well to chemotherapy, and I guess this is partly because platinum is also a double strand breaker, and therefore you're actually doing the same sort of mechanism in a much less refined way. And there's a hint that maybe if they've been treated with a PARP inhibitor, they're no longer sensitive to chemotherapy agents. And I'd like to ask people's opinion on what they feel about that sort of concept going forward into first-line studies. So if you take a BRCA population who you know you might be able to get into relapses and remissions for a number of years with standard chemotherapy agents, is giving them a PARP inhibitor going to stop them being able to do that in the future? Charlie?
Yeah, well, that's actually been looked at. And there have been a fairly sizable series of patients looked at who have had PARP inhibitors and subsequently gone on to receive platinum-based chemotherapy. And there was an abstract presentation at ASCO last year which suggested that there were still significant responses to platinum afterwards.
Well, I think the suggestion was that it only was 53%, so that leaves 47%. That didn't respond to chemotherapy afterwards.
But that's a pretty reasonable response rate in patients who are maybe...
In a multiply relapsed response rate, yes,
exactly.
Because that's when they were looked at. But it's not necessarily in your first and second line. And this is what worries me about the direction that these are going at the moment. But at the same time, that's exactly where they should be going in terms of drug development. And I think that leads me very nicely on to the next question, which is how sure can we be that this PFS2 is actually not just an elongation of the PFS that you've already seen your PFS with your PFS1, if you like. I guess the only additional information is that seems to be more marked in the BRCA wild type, mutant population, and not in the BRCA wild type population. So it's been useful in that context, perhaps.
Well, the benefit of it is that it means it takes some of the confounding effect of crossover out of the equation. So that's why people are looking at PFS2 instead of overall survival in these patients who may go on and receive 4 or 5 further therapies.
Yeah. So, I mean, again, I don't know what you ladies think of PFS3, PFS4. I mean, one could have an endless sort of stand at ASCO to present your next PFS, really, couldn't you?
I think it's an interesting new concept to start with, isn't it?
It
Using
is.
this PFS2, which is something we haven't seen.
Well,
before,
I think it's a fantastic... It's actually one of the first times in my career where I've actually seen people begin to answer the sequential question. Because if you look at, say, breast cancer, you give all of these therapies and you look at giving everything all together, but nobody ever says, well, why don't you separate all of these things and give them one after another and then look at the difference in PFS here. So I think it's a great concept.
It may help to untangle some of those
But I do still have concerns over this resistance issue, I'm afraid. But, you know, time will tell. And I think you're absolutely, you know, for this BRCA mutant population, PARP inhibitors are here to stay, and I think they're going to be a very key part of their treatment. So moving back a little bit, looking at the neoadjuvant chemotherapy and surgery, it seemed that patient selection was the very key issue to all of this. And I think one of the main things in the hall at the discussion was whether we're not particularly good at our surgery in the UK. And I don't know if anybody's got any comments on what they feel about that.
Well, I think the discussion mainly did centre around the concerns around surgical debulking rates and time over debulking taken. And I think the main issue really is that this was actually dealing with already a very poor prognostic patient group, and actually you were improving their outcomes, and this is what we are dealing with on a day-to-day basis, and these are the decisions we had to make, and I think some of the outcomes from this should be actually looking at determining patient algorithms for determining who is most appropriate for these kind of treatments. And this is for patients with bulky disease. We're not talking about, you know, the good debulkable stage 3s. We're talking about, you know, quite.
Yeah.
I think I was quite
disease.
surprised with the chorus as to how sort of poor performance status those patients were. It certainly isn't what we see in all of the trials, because generally we think of patients who go into trials of being the sort of select population with good performance status. So that was quite interesting that we seem to have such a sort of bias of patients with poor performance status.
And I think it's representative, isn't it, of what we see in the clinic, and that's why I think it was an important.
But I also think it's terribly
trial.
important to realise that what we see in our trials is actually oncology trials, and they're therefore much better. And what the surgeons see are often much poorer prognosis patients. And I think one of the key things that didn't come out in this discussion is that they are to be really congratulated on running probably the first prospective surgical trial in ovary cancer outside the Virgo one, because it's very difficult to do these things. I just hope that the NHS isn't going to launch onto the 14-day hospital stay and make everybody do it this way, but there we go.
That's right.
And finally, dose-dense. I mean, dose-dense chemotherapy, I think, is certainly still under scrutiny in ICON 8. It's been very interesting last year to hear an update on the dose-dense Taxol issue. We've now got dose-dense carboplatin as well as Taxol, obviously difficulties over the doses. But I don't know whether you can comment, Shibani or anyone, on why you think perhaps this wasn't quite such a different result with dose-dense therapy as perhaps the Japanese data.
I think one of the suggestions is that we don't see the peak effects of the carboplatin when we give it weekly. That does also mean that they seem to be much better tolerated. The quality of life was certainly a lot better in the group that had the weekly treatments. So it could be that we're not seeing the peaks associated with carboplatin. It could also be the dose of Taxol that was used that was significantly lower than in the other studies, 60 rather than 80 milligrams per meter squared weekly. And as I mentioned earlier, it could also be the sort of pharmacogenomic factors. The Japanese study shows much better progression-free and median survival compared to all studies of first-line treatment. So that would be really interesting from the ICON 8 to see whether we can match that, or whether that group have a particularly sort of sensitive response to carboplatin and Taxol.
Or whether there are any ethnic differences in ICON 8 when it actually...
Absolutely, yeah, absolutely. So I think
Thank you very much.
Thank you.